In a classical case of hyperthyroidism, most of the people will pick up the startling clues of thyroiditis or Graves. But beyond that, the true mastery lies in identifying the subtle, often overlooked clinical breadcrumbs that tilt the diagnosis towards thyroiditis from a Graves disease, where thyroiditis is an induced leak. So let's see, the earache and the jaw misdiagnosis. Patients with subacute recurrent thyroiditis rarely talk about that my thyroid hurts. They often say referdotalgia, pain radiating to the ears or the angle of the jaw. Then there is odynophagia, pain on deglutition. It's often mistaken as a simple sore throat or dental abscess because often there is an ongoing low-grade fever. Then there is a moving pain, the classical subtle clue that the migration of tendons from one lobe to the other over a few days, the creeping phenomenon. The nature of the goiter, the tactile feedback is often more telling than the size of the gland. In Graves, the gland is typically soft to rubbery, and in high flow states, you can feel the thrill and hear the bruit with the stethoscope. While in thyroiditis, the gland is usually firmer. In subacute cases, it can be stony hard, mimicking a malignancy. In silent painless thyroiditis, you may not see a gland at all, enlarged gland at all. Always look for what is not there, extrathyroidal absences. Sometimes the most important clue is what is not there, the stare versus orbitopathy. While in Graves and thyroiditis, sympathetic activity and lid-like and stare is often there due to high T4. Only Graves involves true inflammatory orbitopathy with chemosis, proptosis, and extraocular muscle entrapment. Again, pretibial mixed edema and acropathy will be pathognomonic of Graves because they are TSH receptor antibody mediated and they will be absent in thyrotoxicosis. So whenever they are absent in a thyrotoxicosis, always think of thyroiditis as a possible clue. The viral shadow, always look for a viral prodrome. It could be up to 6 weeks prior to the onset of symptoms. As for low-grade fevers, myalgia, upper respiratory infection, the shadow of an infection is the hallmark of subacute granulomatous thyroiditis, whereas Graves is often triggered by acute psychological stresses, postpartum changes. Then the pulse temperature dissociation. In some cases of subacute thyroiditis, you may notice a relative tachycardia, fever dissociation. While the patient is thyrotoxicosis and has a high heart rate, even if fever is present, the expected heart rate is not to the degree of the fever. So inflammatory nature of the itis rather than the metabolic of oocysts is reflecting this thing. So let's look briefly at what are the features of Graves and thyroiditis. For palpation, in a Graves you can see soft diffuse with or without bruit, while it will be firm, hard or tender in a thyroiditis. Again, pain radiation is not there in Graves, it can be there to the ear or jaw or teeth. Weight loss is usually significant in Graves, while often milder and shorter duration in thyroiditis. Eye signs, proptosis, diplopia, pathognomonic of Graves, while stare and lid-like can occur in both. Prior history of autoimmune is there in Graves usually, but usually viral ARI, URI is there in a patient with thyroiditis, or even pregnancy could be there.